Hi, everybody. Welcome. Thanks for that kind introduction, Barry. My name is Tayloe Negus, and I serve as the market leader for Aon Hewitt in Southern Virginia and the Carolinas. Aon Hewitt is a leading global HR consulting firm, and one of the main areas that we focus in on is healthcare consulting for employers. We also consult in retirement and investments. We consult in talent, and we consult in HR operations. So that is enough of a commercial about Aon Hewitt. The stars of the show are our panelists here today. We've got a great panel here today. It's a mix of employers and providers, and so we're going to hear about some really innovative things that we're doing across those two areas. So I'm going to briefly introduce and let you know who these folks are. They're going to tell you a little bit more about themselves when they have an opportunity to talk about what they're doing in their spheres. First, we have Dr. Karen Babas. She's the Vice President of Clinical Programs and Quality at Walgreens. We've got Bill Ermatinger, who is Corporate Vice President and Chief Human Resources Officer at Huntington Ingalls. We've got Sally Hartman, Senior Vice President at Riverside Health System. And we've got Dr. Bob Kaskaden, who is the Chief Medical Officer at DHG Healthcare. So as we've heard today, employers and providers are having to rapidly comply and adapt to the changing regulatory and business of health landscape. At the same time, they're having to innovate extensively to accommodate new technologies and other advances. Over the next hour, we hope to provide you with some of the best thinking you will find anywhere about how employers and providers are effectively innovating in and adapting to the wild, wild world of healthcare. So without further ado, and with that, I'm going to turn the floor over to Karen, and she will tell you about some of the innovative things that Walgreens is doing.
Thank you, Tayloe. Let me see if I can get my slides up.
You coming?
There we go.
Was that me?
I can do it without slides if we can't get them up. There we go. It's quite a privilege to be with you today. I think we've already heard some very good future thinking. Jeff started it off this morning saying one size does not fit all, and we totally agree. There was a lot of talk about the triple aim, cost-effective care. Pam, in our last panel, talked about consumerism. I'm going to talk a little bit about consumer activism, which is what I think we're all talking about. Nancy said it's all about me as a consumer, and I think that's where we need to think going forward, because that's where the true action is. Walgreens, wow, talk about access. We've got access to people. Over 8,200 Walgreens stores in the U.S. You might have heard last year we expanded globally. We're now Walgreens Boots Alliance. We're in 23 countries, expanding our reach throughout the world. Programs, services, products we create here will be used elsewhere overseas as well. We touch 6 million people each day in our U.S. stores. Additionally, 2 million people are online with Walgreens digital assets. So we have a far reach. We know we can have an impact, but we cannot do it alone. We work best when we partner with teams, with groups, with health systems, with providers like you. So it really is a privilege. I didn't introduce myself. I am a physician. I'm an internist, geriatrician, and hospice and palliative care doc. Was in practice on the side until last year, when I finally decided I'm old enough, I don't have to practice anymore. So what's happening in the industry? I think everyone knows 10,000 people are turning age 65 every day. That's big. Those baby boomers have more financial impact than any other group. I'd be paying great attention to them and what they're going to need going forward. It is, as Nancy said, it's all about me. I want health care when I want it, where I want it, how I want it. I want convenience, I want access, and I want it to be personalized. We didn't talk much so far about personalized medicine, precision medicine, but that certainly is coming in a big way. Genomics is right around the corner. So those of you who don't have our app yet, please go out and get it. Our app is the third most downloaded app in the world, after Amazon and Groupon. And we think that it's a very great app to interact with people. What can you do on it? A lot of things. Remind your loved ones about pills that they need to take. Chat with the pharmacist instead of going into the pharmacy. Hey, I've got a question. Should I take this with food or not? It kind of makes me a little sick. I don't know what to do. Chat with the pharmacist and find out. And then our immunizations app. We gave 7.8 million flu shots last year, in addition to many other immunizations in travel health, in multiple other areas. So we're out there giving you immunizations. How convenient is it when we give you a shot, it automatically uploads to your immunization record? We think that people will need that health record going with them to other, if you're going to a specialist or another doctor, wouldn't it be nice to pull out part of your health record? And obviously we need to expand that even more. Every second we fill 1.6 prescriptions. We refill 1.6 prescriptions. We make it very, very easy and very seamless. And that's why people use it. We're infiltrating pretty much any technology you can think of and adding what we do into what they do. We're creating what's called an API ecosystem, whereby we can connect with any device, application, and we want all that information available first and foremost for the consumer, but then also with the ability to download it, send it to the provider. Our Balance Rewards card is the most used in the US. There's 82 million active users with this card. We're focused more and more on healthy choices and rewarding people with points and therefore money if they make a good choice, a healthy choice. And they can get points by tracking their activities, tracking their steps, tracking their sugars. So this has become very popular, and it's, as you'll see, it's making an impact. We can connect to the usual devices, and we can connect to blood pressure cuffs, sugar checkers, you name it. And it is making a difference. Yes, these people are highly motivated to participate because they chose to participate, but guess what? Along the way, it's having a positive impact on their health. One recent addition to our technology is One Touch Connect. So I don't have my phone here, but you go on the app, you choose that you want to connect, you push your finger down and hold it, boom, your device is connected with Walgreens. You can track, trend, have all your data inputted in one place. Add to that, we've connected with WebMD, and we now have digital health coaches, essentially, digital health advisors, who are inputting educational information specific to your needs based on your profile and doing it live. Each consumer can modify their own homepage however they want. They can see their meds. They can see anything that they want to look at, and it's all personalized. Adherence is very important. If a patient with diabetes doesn't take their diabetes meds, guess what? They end up in the hospital. So with all of our reminders, you can see an improvement in adherence, and the consumer can choose how they want to receive those messages: online, email, phone call, or text. There are a million medical devices out there. We're looking at these devices, and if they meet muster, we're adding them into our ecosystem. Final area we're going into very deeply is telemedicine. I noticed Teladoc is outside. American Well is a very big company as well, and so is MD Live. We've partnered currently with MD Live to provide telemedicine services. Currently we're in 5 states. So very quickly you can choose to go with a physician consult and be connected from your app or your computer with a physician for a healthcare need. We do believe this is going to become more and more popular going forward, and we plan on greatly expanding our telemedicine reach with other new areas. One area that I'm very interested in is behavioral health. Psychiatrists, psychologists, counselors. If you have any family members who've had a psychiatric or behavioral health need, like I have with one of my kids, it's very difficult to find a provider. They're very, very busy. The waiting list is quite long. If you go in to see the psychiatrist, they never touch you anyway, so you don't really need somebody to lay a stethoscope on your child. Using telemedicine is a phenomenal way to reach many people who have behavioral needs. And I see a huge expansion of telemedicine. The states that were against it are now coming along and changing their minds. So I think this is going to be rapidly expanding. And those are my introductory comments.
That's great. Thank you, Karen, very much. Next up, we have Bill Ermatinger with Huntington Ingalls.
Well, thank you for inviting me on this panel. Listening to the speakers prior to us and looking at the panel members here, I think I'm the only non-healthcare expert, so pardon me. So I'm the Chief Human Resource Officer for Huntington Ingalls. A lot of you probably don't know who that company is, but we're the parent company of the Newport News shipyard here. And we also own a comparable size shipyard down in Mississippi and another business unit, oil and gas, in Houston. So we have about 40,000 employees. But for the context of healthcare, I manage 100,000 lives, because that's employees, dependents that they carry. And I will tell you that 70% of HII's healthcare costs is driven by dependents. 70%. So even if I wanted to do some creative things inside our business, I'm only touching the 30% of the world that affects it. So to give you what we have done, I got to give you some historical perspective of our journey, and I bet it's probably very similar to all the businesses in the room. So the top part is a CPI chart. It tells the same story that Dr. Brewer did this morning when he showed DDP. But basically, we have been on this healthcare journey for 30 years, almost to the day. The top chart shows the red line is CPI with medical cost. The purple line is CPI without medical cost. So you can see, starting in the late 80s, all of a sudden medical care started to explode. And for the past 30 years, employers had basically, at a very high level, 3 levers to pull on to affect that red line to bend it downwards. That's plan design, cost shifting, and wellness initiatives. Those are the 3 levers that we've all been playing with. We've all been trying to figure out what is the science and what's that secret sauce of each 3 of those levers. Since the Affordable Care Act has been passed, 2 of those levers are really restricted, as you can see. You know, we are somewhat boxed in on how much we can do on plan design, and we're boxed in on so much on how much cost shifting we can do. So if you think about it, the only lever that's really left, if we want to really get into the healthcare issue, is wellness initiatives. So here's that historical journey that HII has been on, and I'm sure you have been on. You remember the wonderful 80s. That's a decade I think I want back in my life, but that's where HMOs really exploded. Remember, that was the solution. We're all going to go HMOs. And as an HR professional, I can't tell you the wonderful phone calls and letters I got by restricting our employees to HMOs. So we quickly then, went left. I'm not saying HMOs are bad. I'm just saying, but that's a classic example where us as employers, we felt that there was a one-size-fits-all, silver bullet. There it is. Let's do HMOs. And we quickly realized that there wasn't. So we kind of shifted in the 90s to PPOs, which is basically, as we all know, HMOs light. And at the same time, the pharmaceutical costs started skyrocketing. So we started to see the brokerage firms coming about, and that helped us a lot in controlling costs, but employers started losing transparency. And then in the 2000s, we started to offer the consumer healthcare driven plans. That is really probably the very first time employers started to try to think of how to build accountability into their employee. I don't think we did a good enough job of pushing the concept and training them on how it works, but that was really, in my opinion, the first time. And so we've been offering CDHPs for over 10 years. And then clearly we started to work on the wellness initiatives, and we've all done that, right? The flu shots, the health risk assessments, Fitbits, you name it. So what drives healthcare costs? We can all debate on the percentages, but I think in a simple HR brain like mine, this is how I look at healthcare costs. If you look at how much money you spend on a personal level, I think 50% of your cost is driven by your own behavior. And 20% is going to be driven by your access to healthcare. 20% is probably driven by the environment you live in, and 10% on genetics. Now, again, we can all debate on the percentage of that, but I think that's a fair high-level representation. So as an HR guy, I'm thinking, okay, if I'm going to have a healthcare strategy, I can't affect the environment, I can't affect your genetics, but you know what? I can play a role in your behavior and even access to healthcare. So when we started the journey of let's create a healthcare strategy, the first thing we had to do is make sure that it really is aligned to your human capital strategy. A lot of employers, I've seen a lot of my peers just do the healthcare strategy in a vacuum, and you really got to tie it to what is first your overarching healthcare strategy. Second of all, when we built the strategy, we built components that we've never had before. It had to have accountability on both sides, both us as an employer and employees. We had to make sure we had employee choice. I learned from the HMO days, one size fits all doesn't work. So I wanted to make sure I had a lot of offerings and different ways of affecting people's behavior and access to healthcare. Benefits literacy is absolutely critical. It's kind of hard to tell people to be accountable to something if they don't understand it themselves, if they don't understand what tools are out there to help them to modify their behavior. Clearly program improvements, regulatory compliance, and I can't stress this enough, company leadership. We have to figure out a way to get all levels of the leadership in your company engaged in this discussion as it relates to how they relate to their own employees. So as you can see, that's the lens that we kind of look through. And the aha moment for me when we were doing this is healthcare is no longer a benefit as an HR guy. It's an investment. And I say that because for 30 years, I would sit with my CFO who views healthcare as a cost, and I'm viewing it as a benefit. Well, now that ACA is passed, right, it's no longer a benefit. Everybody gets it. It's no longer a discriminator. So the conversation in the boardroom is now shifted. I can't say it's a benefit. I can't say that it's going to attract a certain workforce. So now I have to change the language to healthcare is an investment. That changes the complete dialogue. So this was my healthcare cost, HII in total, 100,000 lives. The blue dotted line up top is by quarter, the net cost is us as a company. That's the true net cost. The green line is the employee. That's their premiums and copays, out-of-pocket limits. And you can see the black line is the trajectory that we were on. I bet if I looked at any other company up in the audience, your trajectory would probably be the same. So in the 2011 and 13 period, we were formulating that strategy I was telling you about. So we've done a ton of things, but on a high level, we did do some plan design changes because we looked at our data, and one of the things that we saw was our employees were using the emergency room as their primary care physician. And by the way, our healthcare plans, when we ran it through the Affordable Care Act model, we were considered a platinum plan. So it wasn't like we had a plan that wasn't conducive for someone to really use the healthcare system. The annual dependent verification process, the last time as an employer I asked you to verify your dependent was when I hired you. Never done it before since, so now we include that as a part of that accountability to ensure that we're covering all the appropriate dependents. We are late in the game on the tobacco-free incentive program. We just instituted that. The biggest question I always get is, why did you choose $55 as the benefit if you're a non-smoker? A lot of companies look at their own data and they do these logarithms and they figure out how much is a smoker versus a non-smoker. And that just got too hard for my goofy brain. So I asked a wonderful consultant, I said, tell me what's the average price of a carton of cigarettes in the United States? They said it's $55. Great, that's the incentive. So if you're a smoker, it's going to cost you a carton. The last one is we invested in people inside HII on the communication side to really tackle benefits literacy. We looked at the population that we did. Again, this is that one-size-fits-all. I did have a post-65 healthcare, but it was one-size-fits-all for all my post-65 retirees across the globe. And we finally went to a healthcare exchange, and so now, as I'm showing you, instead of the one-size-fits-all, our post-65, they chose 277 different plans. they saved on average 30% in premiums, and then they took the money that I gave them and used it on dental and vision and other things. We did telemedicine. As I said, our population really utilized the emergency room. I think it was due to convenience, and they just kind of waited too late. So we've instituted telemedicine, which has been very beneficial for us. And this is the pinnacle corner of our strategy. We're going all in on the deep end with healthcare. We are opening our on-site clinics. I'll be flying down 2 weeks from now in Mississippi to open up that one. And by Thanksgiving, we'll be opening up the Newport News one. This is about a 15 to 20,000 square foot, all-encompassing healthcare center that is dedicated to our employees and our dependents. It is about, as you can see, about 40 healthcare professionals that are going to be in this one-stop shop. Physicians, nurses, wellness coaches, nutritionists, on-site pharmacy, lab work, x-rays. And it's simply $15 for the employee. No copays, no deductibles. And I'm not doing this to replace what we have. Still offering our PPO and CDHP, still offering telemedicine, and now we have an on-site health clinic. That gets to, A, the access problem, but it's more important because I'm changing it no longer for fee-for-service, I'm changing it for it's going to be salary providers, they're going to be able to spend time to try to modify that behavior. Finally, this is now to show you how we've bent that cost curve. So the blue line is what I showed you before. The light blue line is now the cost to the company, and cost isn't everything, by the way. The green line, as you can see, we really haven't changed the trajectory. I didn't do a cost shifting by saying, I know how to lower my costs, I'll just do less, push it onto the employees. As you can see, we haven't done that. And we have not even instituted the tobacco rates in here, nor have we instituted the health centers. I think that's it. I think that's the last slide.
Thank you, Bill.
But yeah, that's how we've been kind of going to the next level.
I have to ask, in your trip from Newport News to Richmond today, were you listening to Culture Club? You said the 80s is a decade you want to give.
No.
You were not. I'm not sure I believe that. All right. Next up, we have Sally Hartman from Riverside Health.
Thank you, Taylor. I'm happy to be here today to talk a little bit in more detail about some of the things that we've done with our employee health plan. I've been with Riverside about 20 years and had an opportunity for the first part of that time to run a joint venture health plan that we had with a provider or with an insurance company as well. We left that business in 2008, but have continued to innovate and use some of those same principles in our employee health plan at Riverside. Here's some of the things that we feel are really the requirements for success in terms of being able to bend that cost curve as Bill's spoken about. For us, the relationship with primary care physicians was probably of the utmost importance. And we wanted to make sure that our employees continued to choose a primary care physician even when we made the switch from, hopefully I'm making that a little easier. We switched, as most employers did, from HMOs to PPOs, but still wanted to be able to have our employees choose a primary care physician and maintain that relationship. So we made that a big part of our plan selection. Additionally, we focus on our employees and their spouses having a well visit with their primary physician every year as part of our program, and I'll talk a little bit more about that. Employee choice and tools relative to decisions on how they spend their money is an important piece as well. And there's two really kind of basic intersections where this is important. It's, of course, when they're about to receive care or if they're shopping to make a decision about where they might obtain care that might have been recommended by their physician. But it's just as important on the front end as they're going through open enrollment and thinking about which plan they might choose for the coming year for themselves and their families. There's, traditionally it's thought in the industry that people tend to probably buy more than they need. So giving employees and their families tools to make sure that they're right-sizing their coverage was one of our key strategies. Population health management, we have started and worked on that over the years and had the advantage of using some really industry specific tools to do some deep data dives. And then being a provider, of course, have the advantage of being able to bring clinical people to the table to help us look at our trends, look at that data, ask additional questions, and dig deeper. So we use a tool that a lot of insurance companies use on our own employee claims data. We, of course, have that blinded, so we're not looking at individual names, but we are looking at it to identify trends and areas of opportunity for us to do interventions. Plan design plays a big role in this. We've evolved, obviously, over the years, I'm sure as many of you have as well. The deductibles and co-insurance is increasing, certainly are having an impact on our employees, but we also have implemented a way for them to make decisions and have those impact their pocketbook by having a tiered plan. So we have a high tiered plan where we're segmenting out high quality, high value providers into that high tier, and our employees receive the biggest benefit if they use those tiered providers, and then they can use 2 other tiers if they choose not to do that. And lastly, our wellness programs kind of wraps this all around. They too have evolved over the years, but they have been very targeted in our company to the specific population needs and things that we've identified through our data analysis. This is a busy slide, and but I wanted to kind of call out how the interaction of our medical home works with the data and analytics. You can kind of think of this as a cascade. Access is key. I agree with Bill on that. And of course, from the Walgreens perspective, access is really what's driving the strategy of having the clinics. We feel our employees, you know, as yours are constantly at work during times most providers are in their offices. So working with our medical group and others, we were able to really give some preference for same day, next day appointments, evening, weekend appointments for our team members, and tag those folks in our medical records so that they could get in when they needed to be seen. We also have the opportunity to innovate on a couple of things that we can try and see if they work. So another thing we did on access was we did do an on-site clinic for about 6 months last year, specifically during the period when our employees do their wellness exams. So we wanted to make that accessible for our employees. So we'll evaluate whether or not we'll do that again. Telemedicine will play a role in this, as does interactions electronically. That's what our Healthy Link system is. We support then the primary care physicians through that next layer, and that is kind of the data and analytics layer, the population health information that we bring back to the providers, analyzed and help to design interventions, and then continue through kind of, basically your typical process improvement methodology. Design an intervention, implement the intervention, measure its outcome, and then go back to the drawing board. We were one of the early adopters in 2015 of a private health exchange. As far as I know, we're the only health system in Virginia that have done that. I'm not sure that that's valid, but that's the last I heard. Bleeding edge, leading edge, I'm not sure which one you would call it, but we did it and we survived. And really, you look at a private health exchange for a couple different reasons. You can look at it from a perspective of, again, helping folks make the right decisions on what plans they might buy, but also being able to move towards a defined contribution strategy. We made the decision basically to implement the exchange just on the return that we expected from right-sizing the plan designs, with the intent that if we wanted to use it as our defined contribution platform down the road, that was great. So you can see here a tremendous shift in folks moving to the higher deductible health plans just in the first year, and some other nice savings that we've realized in this first year. Lastly, our wellness program has, of course, evolved from the typical self-reported activity to, as I mentioned, one that's based on really looking at our population, their specific needs, and incorporating those measures. So we've developed a set of biometrics that are measured by either a visit to our on-site clinic that I mentioned we piloted, or a primary care physician, whether it be ours or any other primary care physician an employee or spouse chooses to see. The details from that are sent to a third-party vendor. Care plans are then developed and implemented, and our spouses are now included in that program as well. So just some of our results, and this is really looking at 2013 plans year to 2014. Really kind of feel good about the good things improving. Our preventive visits are well above the norm. We use the software I mentioned is called Verisk, and Verisk has about 8 million lives in it. So when we compare ourselves to the norm, it's quite a sizable norm. And so our preventive visits are up nicely. And that was actually one of the reasons that we started with that concept of requiring a wellness visit with a primary care physician, because we noticed, probably due to our employees being so busy, that our preventive health visits were very, very low. That has resulted in an increase in maintenance meds, which is a good thing. And then on the bottom, I think it's had an impact on some of the larger costs that we all are facing, your typical admissions, emergency visits, and our risk index overall has decreased nicely year over year. And that's all I have.
Sally, that was great. Thank you so much. Almost right on the dot from a time perspective. And as a reward, somebody's going to have to get you an I Survived the Exchange t-shirt. We're going to have to figure that out.
That sounds great.
Bob.
I'm Bob Kiskadden. I'm the Chief Medical Officer for Dixon Hughes Goodman. I've frequently been asked, what does one of the nation's top accounting firms need a chief medical officer for? And the reason is a significant part of our work is done in healthcare advising and consulting. And we're a very robust organization with about 300 dedicated healthcare consulting professionals who work in 4 basic areas involving finance, CFO advisory, informatics, business intelligence, and reimbursement and strategy. And within strategy, we also have sort of a cutting edge division, which is our Center for Industry Transformation, which is really addressing what are the really critical business issues in transformation in healthcare right now in this time of reform. So that's why they have a chief medical officer. That's me. I've got to say that as a physician who's practiced clinical medicine for almost 25 years now, I'm very excited about healthcare reform. And I think that what people fail to understand is there's really 2 types of healthcare reform that are going on in this country right now. One is payment reform, which is the Affordable Care Act, Obamacare, and the other is provider reform. That's how we're actually delivering healthcare to patients. And that healthcare provider reform has been going on for about a decade and a half now, but it's been a little bit overshadowed by some of the complexities and some of the political issues about Obamacare. It's a big sort of complex system that is more politicized than anything else, but it's really a move in the right direction, and it's created the fulcrum for how we're going to be able to manage changes in provider care at this point. The provider care is really summarized by the triple aim, which you've heard about earlier today, where really what we're doing is we're improving the quality of care, we're improving safety, we're improving patient satisfaction with the system. We're focusing more on wellness than discrete interventions of care, with the idea being that when you pull all these things together, you manage your utilization, you're going to actually have a lower cost to a system that right now is coming close to about 18% of the gross domestic product. Really what it's done is this triple aim has shifted the reimbursement system from a production valued system to more of a performance value system. We talk about our reimbursement now being more on volume in the fee-for-service market and being more on value in the future. And what we used to say was, if you have no margin, you have no mission. Well, now what we're saying is, if we have no outcome, you have no income. And it's really a great approach. People ask, why didn't we do this a long time ago? The fee-for-service system is really a system of perverse incentives. And in fact, a patient who gets surgery and does well will reimburse the hospital and the surgeon less than if they have complications and have to be readmitted, reoperated on, and have an extensive management of that infection. So really, we've moved away from that system of perverse incentives to this fee-for-service, from this fee-for-service to more of a value-based system, and it's a great approach. What we have to do as healthcare advisors in Dixon Hughes Goodman is to get people to recognize that there's a burning platform. We didn't create it, but it's out there, and we need to bring that into focus. We need providers to realize that these changes are inevitable, and there's no way to really, stand your ground and say, I'm not changing with this, and that there's a great need for urgency, because in fact, we're in the middle of it right now, And if you look at this very complex slide, you can see the vertical line off to the right. That's May of 2015. And these are all of the CMS value-based initiatives that either give us more money or hold money back. And if you look at where we are today, the measurement period for a lot of these initiatives is already over. And they are determining what's going to be paid in 2016, 17, 18, 19, and it's already been measured. There's a saying among pilots that if you're having trouble in your liftoff, the only thing that counts is the runway in front of you, not the runway behind you. And we've got a lot of runway behind us right now in healthcare. So we really need to move forward. And what we do in healthcare advising with Dixon Hughes Goodman is we try to find that sweet spot. We try to help organizations move from a fee-for-service system into a value-based system, because that is going to be a very precipitous change at some point. CMS makes a rule, and October 1st it's enacted, and that changes the whole game. Reminds me of a cartoon I saw in the New Yorker where there were two physicists looking at a very complex problem that had a beginning and had a conclusion, but they couldn't figure out what happened in the middle, and so they just said a miracle takes place. And I think, you know, if you're looking at healthcare, that you can say the same for fee-for-service. How do you move from fee-for-service to a value-based reimbursement system and manage that miracle a little bit better? And what we do at Dixon Hughes Goodman is we do what's called a risk-capable assessment. And then we help organizations improve their risk capability to move from a fee-for-service or get paid for your work to getting paid for the value or the outcome of that work. And our risk capability system really has three major components to it. The first is, do you have the data to be able to manage your system? Secondly, do you have the revenue structures that will adapt to this new value-based system? And finally, do you have the clinical enterprise maturity in your governance and in your physician alignment to really implement any of these new changes? And we look at it as aligning the clinical enterprise maturity with the market to make sure that they have control over utilization, their focus on wellness, and this whole volume value imperative as well. And where we really try to help organizations is if they're misaligned, if they're still working on their revenue system, their fee-for-service, and their market has already moved ahead to giving either penalties or added incentives to organizations that have value-based care. One of the great tools that we've developed is for bundled payments. Right now there's 48 discrete DRGs involved in the bundled payment system, which is elective, but within the next 3 to 5 years, bundled payments will be a requirement. What we can do is we can take an organization's data, put it into this tool, and we can tell them today whether they're risk capable of moving into a bundled payment system. And many of them are, many of them aren't. And if they are, even if they are risk capable at this point, we can then drill down and we can say, how can you improve? Is it reduction in readmissions? Is it a decrease in the use of SNFs? A variety of different things. And so this is one of the informational innovations that we're using to help people become more risk capable in this transforming market. We're looking to help people do accelerated change, accelerated transformation in their processes, in their informatics and intelligence, technology, their relationships inside and outside of the organization, and their overall culture of their organization. Moving from doing things to doing things of value and being reimbursed for that outcome. As I said, the Center for Industry Transformation is one of our cutting-edge think tanks. We're also participating in the Global Center in Cleveland, which brings multiple different industries together to find innovative solutions in healthcare. So that's what we're doing at DHG today.
That was great. Thank you so much, Bob. It was, a miracle happens here. That's a great cartoon. So moving from fee-for-service to value-based is like reconciling quantum physics and relativity.
Yes, that's right.
It's that kind of challenge. That's excellent. So we are now going to, obviously, these folks are on the front lines of innovation in the employer world and out there in healthcare. Providers got a lot of great ideas. We're moving on now to the question and answer session, part of the program. And so we're going to start with Karen. And Karen, based on, it was fascinating to hear all the different technologies that you were using at Walgreens to improve folks' health. what do you see on the horizon in terms of new technologies that might be employed to continue that trend of health improvement?
Well, I'll talk about one of our partners who is Qualcomm. If you're familiar with Qualcomm, they put the chips in almost every smartphone in the world. They have a lot of connectivity. I think they came up with the 3G, 4G stuff, so network. Qualcomm is working with provider groups, and we're one of the provider groups, to manage by exception. So that if we upload data to them, say you have a heart failure patient and you're doing daily weights, and we upload the weights to them, they can then shoot all that information out to a health system, a case manager. She can look at 500 patients in a day and figure out who's heavy, who needs a call, who needs an intervention. We have to start using healthcare intelligently and really focus and target on people who need the care the most. So that's one of our innovations. Another one is, again, back to access. Many of you may have read about Theranos. Apologies to LabCorp outside. We have partnered with Theranos, one drop of blood and we can do 40 tests. Cheaper, faster, with less pain. So that's another innovation we're working on.
Thank you. So are you working directly with employers, or are you bringing the suite of technologies to employers and
All of the above,
Yeah.
to provider groups, health systems, insurers, and employer groups.
are the other pharmacies out there, CVS or others, doing the same sort of thing, or is this,
Everybody copies us.
yeah, all right. Go Walgreens. Walgreens is the way to go. Next up, I have a question for Bill. Bill, it looks like you had great success with your strategy, improving the cost profile of your healthcare programs. Can you speak to enhancements you may have had in productivity and what those meant to Huntington Ingalls?
No. I'd be a little facetious. I mean, it's really hard to measure the productivity needle as it relates to healthcare. First of all, healthcare is the long game. It's not like if you're on a manufacturing line, you stop the line, turn it off, switch out a gear, turn it back on, and now you got more widgets going through it. So the investment you're making into healthcare to see if that measures higher productivity is really hard. I know there are a lot of smart people out in the world that try to measure that, but sometimes you just have to go with your intuition and gut. For example, let me just see a show of hands. How many people believe that if you're healthier, you're more attentive at work? How many believe you're more productive? You just saved me $1 million in consultant fees to prove productivity.
Now, wait a minute.
I mean, I'm serious. And I think that's the catch, and that's the problem that we have in our boardrooms, is because you do have a business to run. You are obligated to your owners, whether they be shareholders or your own, and you got to prove that ROI. And so a lot of leaders are saying, show me the data, show me the data, show me the data. And it's really hard to do that with healthcare. So sometimes you just got to take a leap of faith. Sometimes you just got to say, what does my gut tell me? Do I want to make this investment? Is it a part of my strategy? That's part of my human capital strategy to make sure I'm attracting and retaining the best employees to execute my business strategy. So the productivity, I get it. I hear it a lot. I can measure what you saw, but I couldn't tell you if I went out to the 40,000 shipbuilders, did their productivity increase because I introduced telemedicine? I don't know. It might have been a piece of it. Could have been the safety program that we instituted. Could have been the leadership development that we're trying to train our leaders on. Could be the workforce development. I think it's like we're using car analogies. Healthcare is just one piece of the car to make it work, but it's not the only thing.
Are folks coming to you and saying, with regard to the on-site clinic, hey, thank you, that is helping me?
Well, it hasn't opened up yet. We're, like I said, in 2 weeks. We actually opened up
sorry.
the one in Mississippi, and the one in Newport News will open up. Telemedicine has. I've gotten more responses on telemedicine of people saying, thank you so much. That has really, really helped me on cracking the access nut. It's 2 in the morning. They need to get a hold of a board-certified physician that can prescribe ampicillin for their child to an all-night pharmacy. That's really helped.
So it's an employee relations win.
Absolutely.
Yeah. Sally, So you talked about your enhanced analytics that you have in place. Do you have an example of a program that you've implemented, an intervention that you've implemented based on your enhanced analytics that identified some area of opportunity, either with patterns that you see in the data or risk areas that emerge?
Sure. Let me see if this is working this time. Yes, we, like Bill, pretty much embraced that philosophy of just try it. And so we pilot things all the time. One that we started in May of 2014, so it's just coming up on a year, was to address probably our top chronic disease issue that we had in our employee population was diabetes, and I'm sure that's not unlike many of yours. So what we did was we designed a pilot where we offered to our employees the ability to receive care, medications, and this was just not primary care, this was specialty care. It was anything that they needed related to the diagnosis of diabetes with no out-of-pocket. Going back to one of the comments I made earlier about that relationship with the primary physician, we feel it's very important to clarify when we're offering a program like this to one of our employees that it is on the recommendation of their primary physician. It's not coming from the employer, it's not coming from the third-party insurance company. And I think that's an important point for me to share with you because it carries a lot more weight, we believe, to have that come from the primary care physician. So anyways, we made the offer via those physicians. We then tracked for a year blood sugar levels, BMI levels, and blood pressure. And we had some really good results. So far in our pilot, we saw an 11.5% decrease in blood sugar levels over that year. We saw a 4% decline in BMI. And as far as blood pressure, the number of individuals that were 140 and above, 140 over 90 and above, went from 22% to 15%. So we are very happy with that, and next phases for us would be to expand that. That's a capability, again, that many providers have, so I would encourage employers in the group here, as you're looking at your health insurance, make sure included in your network are providers that can do those types of things for specific populations.
Thanks, Sally. So Bob, the move from, again, this is the miracle, the move from fee-for-service to value-based reimbursement. Some in the health reform arena suggest that it's physicians that are a barrier to moving in that direction, to arriving at the place for value-based reimbursement where we want to be. The physicians are not moving quickly enough and changing fast enough to get there. You're a physician, so I think it's a fair question to ask you. Is this true? And if it's true, how can we get physicians to move at a faster pace so that we can get where we need to go?
Yeah, I agree with that, and I think we're seeing it on a lot of fronts. There are physicians who are more than willing to adopt it, but I would say that a majority of them are a little slow moving in that. And I think there's really two major factors the way I see it. One is that I had my first job in hospital management in the early '80s, and we've been telling physicians since then that big changes are coming, and it's going to change the way they practice, and it's never really shown up. And so they look at us as henny penny, the sky is falling, and it never seems to. But I think this burning platform that we have right now is something that's real, and we're experiencing it. And while they've experienced this sort of insensible loss of revenue, they're now seeing big changes with EHRs and additional regulations like that. So I think on one hand, we've not given them, or they don't perceive that we've given them the straight story. But I think more importantly, in a physician's training and in their practice, they are responsible for outcomes. They're responsible for their patients' outcomes. And we're bringing them to a system where we're saying, we want you to implement processes. And by the very definition, if I hold you responsible for a process, then I am responsible for the outcome. Mm-hmm. And so the more we push these processes at them, the more they feel like they don't have enough autonomy to really manage the outcome. And I think they're going to be very reluctant to abdicate their responsibility for the outcome as we do this. So I think it requires a huge culture change and an educational process for physicians to make them understand that the processes that were really embedded in healthcare reform are going to result in improved outcomes and bring them along. I think we've been very expedient in just saying, sign up for an ACO, do this, do that, These are intelligent people who need to be brought along with this process. And I think the time is right now to be doing that. And I think part of what we need to do in our advisory role is to help with this physician alignment as we move forward with transformational medicine.
Critically important to have them on board and lead that process. So now is the fun part of our presentation today. This is the lightning round. I'm going to ask one question to each of our panelists here and give them the chance to respond. So we've heard a lot of great ideas today that have had positive effects on organizations and health populations. Ask the group here, do you have an example of an innovation that did not work, where you took a risk and tried to do something and it didn't work and had negative effect? Or are there some pitfalls that you would suggest that everybody try to avoid at all costs? And so why don't we go in reverse order, Bob, and I hope that's okay. We'll start with you and come back this way, but if you could give your quick thoughts on that, that'd be great.
Okay. I think one of the greatest pitfalls is what we were talking about, where that miracle occurs, and helping organizations move in that direction. One health system that I worked with in Illinois was very forward-thinking in moving towards this value-based system. And what they found was that they reduced their utilization significantly, they decreased their readmissions significantly before there were reimbursement mechanisms to compensate for that. So I think, while we're all feeling like we're a little bit behind the curve in a lot of things, there's no problem with HCAHPS and patient satisfaction moving forward. But as we change our reimbursement systems, we have to be very sensitive to what that sweet spot is, and that you can do radical change. If you drop your readmission rate from 18% down to 12% by some activity, and that happens rapidly, if you're not reimbursed for that, you can wind up losing a lot of money. And so that's where I think that's the greatest risk that we have right now in moving from this fee-for-service to a value-based system.
Thank you, Bob. Sally?
I think I'll address the pitfall question. I think, as I sit both on the provider and employer side, would be probably the biggest thing that is a tendency is to not change, right? This is a huge opportunity with the Affordable Care Act and all the things that are going on to use that as a way to facilitate change. And demand from third-party payers, brokers, whoever it is that we're working with, that they continue to innovate and offer the types of plan designs that we think might work best, whether it be a tiered network or a narrow network of some sort, and make sure that they're addressing the employer's needs from that perspective.
Thank you.
From my standpoint, I think everything I've done up to this day has been a failure. Otherwise, I would have.
I thought you were going to go the other way with
I
that.
know,
I'm
right?
serious. I mean, no, the pitfall is the one-size-fits-all. I've learned that in 30 years doing this. I've tried to do the one-size-fits-all. So taking away employee choice, I think backfires. The other thing is, do not wait for whether it be the state or the federal legislation to fix your problem. It's not. And I would even say that the healthcare industry that provided the delivery mechanism is not going to be the panacea. We get so focused, I think, in this country that, everyone's using the analogy of cars. You blow your engine, we're fixated on which one is the best mechanic to fix it, who has the highest quality, are they convenient, we do it. You know what? If you just change your oil every 6,000 miles, you wouldn't have a blown engine. So I think we got to get the fixation on us as individuals, on the accountability. And now how as an employer can you help that? I think that's what I've learned in the last couple of years.
Thanks, Bill. Karen?
So Walgreens really is constantly in innovation mode. We have pilots going all the time. I was just looking at hearing. We're doing hearing checks and hearing aids as a new pilot, as an example. Our motto is fail fast, but I would also add know your ecosystem really well. Know who your partners are and who you work with. So where we failed miserably was trying to get our nurse practitioners in our healthcare clinics to deliver good diabetes care. They could do pieces of the pie, they couldn't do the whole thing.
Yep.
We found when we partner with a health system and do pre-diabetes screening or insulin education, pieces of that, we could do it very well. But handling a diabetic patient is too complex. We have to partner with other members of the ecosystem.
Fail fast.
Fail fast.
So I've got to go get my oil changed. I don't want my engine to blow up. This has been great. Thank you to our esteemed panelists. If we could get a round of applause for these folks.
Good job, guys.
I hope that was helpful for everyone.